Okay, so today we are going to discuss approach for contraception in minors. So to begin with, let's have a look at this approach, how to approach any scenario wherever a minor comes to you and they ask for contraception. So how do you approach that station? Let's discuss this approach. So keep that in mind that whenever a minor is someone who is less than 18 years of age, and whenever they come to you, they ask for contraception, the basic approach should be in your mind so that you should be able to tackle them. You should be able to see whether prescribing contraception is in the best interest of the minor or not. Okay, so whether you will prescribe the contraception or not. So let's begin. So basically, you will be starting with same approach, that is doing grips, greet, build a rapport, introduce yourself, paraphrase, or state the purpose of consultation, and then with a smiling face, give a smile as well. Okay, and you need to explain the practice policy as well. That normally it's a practice policy that we do not see individuals or children under 18, and we usually ask them to be accompanied by their parents, because it's a practice policy. Okay, and then you can say that, okay, as you are already here, so I would be happy to see you today. Okay, and then you need to offer confidentiality, because it's somebody is coming to you, they either do not want to discuss it with their parents, or they are afraid to discuss it disclose to anyone, so that's why they are here on their own today. So you need to ask, okay, are you here on your own today? Do your parents know about it, that you are here? And have you informed your parents about your that you are in a sexual relationship? Okay, do your parents know about it? So you need to ask those questions, and then you need to offer confidentiality and let them know that, okay, whatever we discuss here will remain between us and the medical team, because most of the times children do come to the GP practice and they ask that, okay, please do not inform our parents, because if they would come to know about it, they would get angry. So then you need to, after offering confidentiality, you need to take sexual history. You need to ask for, okay, how long have you been sexually active? What kind of sexual relationship are you in? Is your partner male or female? You need to ask about partner's age. Okay, whether how old is your partner, who is he? And you need to ask that uh, has he ever expressed any abusive behavior towards you? For example, has he ever abused you sexually, or has he ever forced you to do something that you would not like to do? Okay, so you need to ask all those things. You need to assess for abuse as well, and then you need to rule out contraindications. Take history for contraindications. For example, somebody might be presenting to you, they might ask for oral contraceptive pills, so you need to rule out contraindications such as high blood pressure, diabetes, migraine, okay, any underlying cardiovascular diseases. So you need to rule out all those, any bleeding disorders, any history or family history of CA. Okay, so then you need to ask about the menstrual history after you have ruled out the contraindications, because based on the history, you need to decide whether you will be giving combined oral contraceptive pills or you will be giving progesterone only pills. Okay, so you need to take menstrual history. After that, ask about menorrhagia, any bleeding disorders, and ask about the normal flow, normal days of cycle, and all those things related to menstruation. Okay, and you need to ask about previous contraception as well. That have you ever tried any form of contraception? What do you understand about contraception? What kind of contraception would you like to use? Okay, and have you ever had an experience of using any sort of contraception? Okay, so you need to ask all those things about contraception. Maybe the person or the female who comes to you visiting you, she will be telling you that, yes doctor, I've been using condoms, but now my partner doesn't like them, so I would like to go for oral contraceptive pills, or I would like to go for injectable contraception. So you need to ask, and then what you need to do is, in elderly you prescribe it, but in minors you need to assess for something which we call as Gallic's competency or Gallic's competence. That is how you will be asking. There are certain questions you need to ask them, that okay, I need to ask you a few questions to check your understanding, that why do you need contraception. Okay, can you explain it to me, why do you need contraception, and what would happen if you do not use contraception, and do you know some of the risks of being in a sexual relationship and using contraception. Okay, and then you assess for Fraser criteria. You ask them to see that, okay, you ask Gallic's competency, you need to check the competency, you assess Gallic's competency to see and to check their understanding, whether the minor or that person is able to understand why they need to use the contraception. Okay, what are the risks and what are the benefits of using contraception. This is to assess their competence. Okay, capacity, you need to assess the capacity through Gallic's competence, and you need to assess for Fraser criteria. Okay, whether this is the criteria for prescribing contraception, whether you can prescribe or not. Is it whether prescribing contraception is in the best interest of the patient or the person visiting you, or whether it is something that could be harmful or that could be dangerous for the person. Okay, so you need to ask few questions. You will be asking, do you think you can try and talk to your parents about your relationship? And you need to convince them. You can ask them, and they would say, doctor, our parents do not understand, and they would get angry or they would get mad at us. So you can tell them, you can say that, okay, your parents, once your parents were of your age at one point, so they might understand. Okay, and ask them that, how would you feel if you are not prescribed contraception today? And if you are not prescribed contraception, do you think that that it would stop you from being in a sexual relationship? And would you consider using condoms? They would also protect you from sexually transmitted infections. Okay, and contraception does not protect from STIs. Bear in mind. Okay, so after assessing this, after assessing Gallic's competence and doing Fraser criteria, there are certain discussions over Fraser criteria, that when you will be prescribing and when you will not be prescribing the contraception. So there are certain discussions. Prescribe contraception only if the following criteria are met. The young person understands the practitioner's advice. Okay, so you have advised them to inform their parents, they understand, and you have advised them that, okay, there are certain side effects of contraception, they understand what are the side effects, they might already know, they understand the side effects. So it means that they understand your advice. So you, in that case, you can prescribe. The young person cannot be persuaded to inform their parents or will not allow the practitioner to inform their parents. Okay, so you couldn't convince them, or they do not want, despite you telling them that they should inform their parents, but they would not inform their parents. So you can prescribe them contraception, knowing that they would still continue the same, they would be in the same sexual relationship. So you can prescribe. Okay, the young person is likely to begin or continue to have sexual intercourse with or without protection. Okay, so whether you are going to prescribe it or not, they will still be in the same relationship, they will continue without using contraception. So it is better to prescribe them. It would be in their best interest to prescribe them contraception. Okay, and the young person's best interest requires the practitioner to give contraceptive advice or treatment without parental consent. Okay, so parental consent is not necessary here. Unless he or she receives contraceptive advice or treatment, the young person's physical or mental health is likely to suffer. Okay, so if you are going to prescribe contraception to somebody and you think that their mental or physical health is going to suffer from it, you won't be going to prescribe them with any contraception. Okay, and then you need to rule out pregnancy. For that, you would be asking them, okay, we need to, because you have already taken menstrual history, but you need to rule out pregnancy. So double check, confirm it. You will be asking for urine sample. you can say that okay, whether it would be possible, or will it be possible for you to give us urine sample. We would like to confirm, we would like to exclude pregnancy, we would like to confirm. Okay. And examinations is, then you would be doing examinations, including abdominal examination and taking observation. You will be starting with OET. Okay. Observation, examination, and then targeted examination. So what you will be doing, you will be checking observation, including blood pressure, pulse, temperature, oxygen, and breathing. And also you will be checking their BMI, and also their abdominal examination. Okay. And then explain different options of contraception. Then you would say that okay, we have different options of contraception. What would you like to go, what would you like to go with? So there are certain options. Would you like me to explain them to you, or do you have anything in your mind that you would like to take? Then they would either say, doctor, I just want to go for oral contraceptive pills, I just want to go for injectable contraception. So they would be telling you, and you need to ask them, okay, what? And if they would say, okay, doctor, you can tell me about different options. So you need to narrate those options. Okay. So we have combined oral contraception, which include vaginal rings, transdermal patches, and pills. POPs, that is progesterone only pills, intrauterine contraceptive devices, and levonorgestrel IUS, intrauterine system, and barrier methods, that are condoms. Okay. And you need to screen for STIs as well, because they have been in a sexual relationship. So you need to ask them to go for screening for sexually transmitted infections. There is a possibility that they might be having, or that they might get this what do you say, sexually transmitted infection. Okay. So you would be following the more or less the same approach. You need to follow this same approach in all those scenarios. Okay. So let me begin with the scenarios. So you are an FY2 in contraception is a 15 years old female. Since she's a minor, so she's less than 18, she's 15 years old. So you are FY2 in GP surgery. Heather Watson is a 15 years old female who has made an appointment to see you, talk to the patient, and address her concerns. Okay. So counseling scenarios, most of the time they come with a short statement. You might not know until and unless you enter the cubicle, you start the conversation, you might not know that what scenario this is. Okay. So when you begin, then you will be asking, okay, the patient, she has come to you, she might tell you, doctor, I need contraception. Then you would follow the same approach. You will start with, you will be doing grips, and after the grips you would be asking telling them about practice policy, that what is the practice policy, what we normally do. We normally ask young ones, or somebody of your age, we ask them to come along with their parents. And okay, as you are already here, I would like to see you today, so can you tell me how may I help you today? And then you need to tell them, okay, she would be saying, doctor, I need contraception. So you would tell that, okay, let me see what kind of contraception, or how can I help you in this regard. So I need to ask you a few more questions. Can you tell me, do your parents know about it, that you are here today? And have you informed your parents about your relationship? Okay. And are you here on your own today? You will be asking this question in the beginning, that okay, are you here on your own today? Do your parents know about you coming over here? And have you informed your parents about your relationship? What is the reason you have not informed them? Okay. You need to ask all those questions, and then you need to offer confidentiality. The female might not tell you, the doctor, okay, I just want contraception. She might not tell you unless you offer confidentiality. You should tell them that okay, whatever we discuss here will remain between us and the medical team. Okay. So then they might tell you that okay, doctor, I would like to go for combined oral contraceptive pills, so can you prescribe me that? And then you need to take sexual history, and then go for history of contraindication. You need to rule out contraindications. And here I have written that she has got migraine with aura. So you have to rule out migraine. There are contraindications to prescription of combined oral contraceptive pills. You all of you might have studied, and rather you must have studied in PLAB 1 preparation that there are certain contraindications to combine oral contraceptive pills. So migraine is one of them. So you have to rule out migraine, and then because you will be doing your history, you will be taking this when you will be starting with the history. You might come to know, or the patient might tell you, the doctor, I have this medical problem. So you need to rule out past medical history, medication history, allergy history, and you need to rule out all those things. And after that, ask for menstrual history and ask about previous contraception, and then you need to assess for Galix competency, and then Fraser criteria. And you will be deciding. You won't discuss these discussions with Fraser criteria. These are discussions are for your convenience, that you should know that you could not persuade the young one to inform their parents, or they would still continue the same sexual practice despite uh, uh, whether they are prescribed or not with the contraceptive pills. Okay, so these discussions are for your convenience, so that you can decide whether is it in their best interest to receive contraception or not. Okay, so this patient has got migraine with aura, so you will be telling, in this case, combined oral contraceptive pills will be contraindicated. So you need to discuss, you need to assess for their any abusive relationship as well. Ask about the partner's age, and she will tell you that, doctor, I'm in a relationship with my class fellow, or he's 16 years old, or he's of the same age. That means, okay, they are like of the same age, and no sign of abuse, or you could not find any mm, sign of abuse, so you can prescribe them with contraception. Okay, but you will be, when you will be discussing those contraceptive options, you will be telling the patient that, okay, we have got combined oral contraceptive pills, but they are uh, contraindicated in your case because you have got this medical condition. So we do not prescribe this medication in this. Instead, the better option for you would be progesterone only pills. Okay, we can go for progesterone only pills. So you have to prescribe this to this contraception to this young one who is 15 years old. Okay, and after ruling out pregnancy and doing examination, and you will be discussing this option with him. Okay, with her, sorry. And let's go for another scenario. This scenario is the same approach. We will be following the same approach in all the scenarios. Okay, but there are certain strategies where you need to rule out that whether somebody is in an abusive relationship or not, whether it is in their best interest to be prescribed with contraception or not. Okay, so emergency contraception in a 14 years old. You are FY2 in GP, 14-year-old has come to request emergency contraception pill. She had unprotected sexual intercourse last night. Talk to her and address her concerns. Okay, so what you need to do is, you need to ask, patient would be the person who has come to you, she would be saying, doctor, I need emergency contraceptive pill. Then you will start with your conventional approach, that is doing grapes, asking for whether she is here on her own, explain the practice policy, go for confidentiality, and then ask for, okay, what do you know about this pill, why do you need this pill? And then she would say, doctor, I had sexual intercourse, unprotected sexual intercourse last night, so I need it. So you can ask that, what do you know about it? And then you will start taking history, and then you will take this sexual history, assess for any abuse, and after that, what you need to do is you need to rule out any contraindications, take menstrual history, and previous history of any type of contraceptive use. For example, she might be telling you that, doctor, we have been using condoms, but last night my partner did not use it, or he doesn't like it anymore, so this happened. Okay, so you will be telling the patients, oh, okay, we have got different, then you need to assess. And since the partner is she is in relationship with her classmate, so you can prescribe her. Okay, you, after assessing this Galix competence and Fraser criteria, if the Fraser criteria is met, then you can prescribe them with contraception, and you can tell them. And she would ask you that, "Oh, doctor, can you tell me that how can I use this pill?" So you need to tell them that okay, here is a pill, I'm going to prescribe you this pill, you need to take this pill. If you vomit this pill, then you can use another pill after 2 hours, and I can give you, you need to use protection, or you need to go for long-term contraception, because this is a pill which can be prescribed once only in a month's time. So you need to go for long-term contraception. Okay, so you can advise them on long-term contraception, and you have to prescribe emergency contraceptive pill. Okay, that is Livonelli or 11. Okay, so you can prescribe them with the levonorgestrel. You have to give them emergency contraceptive pill, and you can prescribe her and ask for long-term contraception, and also convince them and persuade them to go for sexual screen for any sexually transmitted infections. Okay, infection screening. So the next is contraception in a 14 years old. So you are FI2 in GP surgery, 14 years old, has made an appointment to see you, talk to her and address her concerns. Now, this is the same scenario, same person has come to you and she's asking for contraception. But the thing over here is that she is in a relationship with her teacher. She is in a relationship with her teacher. So here, this is a case of child abuse. So what you will be doing, same approach, and then when you will be asking the age of the partner, so she would be a bit reluctant. She would say that, okay, doctor, whether does age really matter? Okay, so you need to ask that, okay, can you tell me about your partner? How old is he? Has he ever asked you to do something that you would not like to do? And you need to assess for abuse. She would say, no, doctor, he's someone I know, he's very nice to me and he takes very good care of me. But when you ask the age, she would say, the doctor, she is, if she is not opening up, you can ask that, okay, could you tell me whether he's your classmate or somebody who you know, or somebody in your college? You can ask these sort of questions to dig out from her. Okay, and then she would be telling you, doctor, he is my teacher. And then you will ask the age of the teacher. She would say that, the doctor, he is 27 years old, or he is 30. So she is herself, she is 14 years old, and her teacher is 30 or 27. So you need to tell the patient, then you will be assessing this Fraser criteria. You will be assessed for Galix competence, Fraser criteria, and then at the end, you won't be prescribing the contraception, and you would be telling the patient that, okay, prescribing contraception is not in your best interest, because the relationship that you are in is could be dangerous, because there are certain relationships which are not allowed, or they are illegal. For example, for a teacher to be in relationship with his or her student, or a doctor with his or her patient. So the relation that you are in is something we call as child abuse, because he is much older than you, and we need to inform the authorities. So you need to inform child protection services, you need to involve child protection services, and even you need to inform the police, and you will be informing, you will ask the child, or you will ask this girl to inform her parents, and you need to inform, you need to involve her parents yourself as well. Okay, so what you need to do is, you won't be prescribing contraception. You need to tell them that you are in a relationship that could be a sort of child abuse. So we need to inform the authorities, and you will be informing child protection services, and even police can be involved in it, and you need to inform the parents. Okay. And you won't be prescribing contraception. You would refuse that, okay, I'm sorry, prescribing contraception or giving contraceptive pills is not in your best interest, so I won't be able to help you in this. And then you would say that in future, if you would like to uh, ask for any contraception, you would like to go for any contraception, I would be more than happy to help you, but at the moment, I need to inform the relative authorities. Okay. These are easy scenarios, so that's why I'm going quickly over them, so that we should give much time to the coming scenarios where they need explanation, because approach is the same. Okay, now here is an other scenario, which is contraception in a 30 years old female. So she is already adult. So scenario A is, you are an FY2 in GP surgery. Sue Hale, aged 30, has made a routine appointment to see you. Please talk to the patient and address her concerns. Okay. And B is, your boyfriend, the same scenario, and your boyfriend used condoms and you have tried diaphragm as well. You have had DVT 2 years ago and you were treated with warfarin. Last smear was 1 year ago and it was normal. Your last menstrual period was 5 days ago. Okay. So you can see that from this the second scenario, scenario B, she has come to you and she is asking for some contraception, which is, you need to discuss different contraceptive options with her, because her partner has tried, they have used barrier methods, including the condoms and also the diaphragm as well. But now she is here, and she has had DVT. So she had DVT. It means that oral contraceptive pills, COCPs, combined oral contraceptive pills, that would be contraindicated in her case. So you won't be giving combined oral contraception. So you need to discuss. You will be starting with the same approach grips. There here no need to ask for any this confidentiality or whatever, because whatever the patient comes to you, they discuss with you, it is always confidential. You cannot breach confidentiality. The patient has come to you, it means they trust you. That's why they are here. They are here to discuss their problems with you. So obviously it would be confidential. And you do not need to explain the practice policy, confidentiality, anything like that. You will just be taking this sexual history, ask for, you can assess for sexual abuse, ask for partner's age, and you can do all those things over here, because she is married or whether she is in a relationship. You need to ask about the relationship as well. Okay, there could be cases of abuse as well, so you need to rule out it. And then you need to take out history of contraindications, medical, a sort of medical history she would be telling when you ask about any past medical history or medication she used, any allergies, and then any travel history. She would be telling you that I had DVT, and then you need to, it would come to your mind that, okay, I wouldn't, I won't, I would not, I shall not be prescribing her with the combined oral contraceptive pills. Okay, because they increase the chance of clot formation. So you need to take menstrual history and ask about previous contraceptions. And after that, what you need to do is, you should be able to explain. You will be excluding pregnancy and doing examination and all those stuff in this scenario as well. Okay, so you need to explain the following types of contraception. You should know, rather you must know the type, the duration, the duration, how long does this contraception last, and what is the failure rate, and what are the contraindications. So COCPs, they need to take it daily with break of 7 days. They need to take it for 1 month, for 1 month with 7 days dummy pills, and 21 days those combined oral contraceptive pills. So they have to take it with a break of 7 days, and failure rate is 3 out of 1000, means every 3 women. How you would explain it? You would explain it that, okay, every 1000 women using combined oral contraceptive pills, out of them 3 still get pregnant. Okay, you can explain it. So it is something we call as the failure rate. Failure rate is explained as if we have got a population, or we have got 1,000 women taking oral contraceptive pills, so there is a chance that 3 of them might get pregnant. So it means this is the failure rate, which is 3 out of 1,000. And this is contraindicated in patient because it is she's having DVT. She has been diagnosed with DVT, so it is contraindicated. And side effects could be, you can say, intermenstrual bleed, clot formation, increased risk of blood clot formation, you can say. Okay. And POPs, progesterone only pills, is they need to take it daily without any break. Failure rate is same, and side effect is intermenstrual bleed. And because you must know these types and failure rates and contraindication, because there are certain patients where the patient is forgetful or they do not want to take oral, so you need to convince them for injectable forms or patches or intrauterine devices as well. So the patches need to be used weekly, and failure rate is 3 out of 1,000, and side effect is intermenstrual bleed. And Depo-Provera, it is IM injection, which for which the patient has to go to the GP, and they need to take this injection once every 3 months. Failure rate is 2 out of 1,000, and side effect is intermenstrual bleed. Implant, so this is a device which is inserted in the skin, inserted under the skin, or under local anesthesia, or it could be inserted on the arms, or it could be inserted over the arms, and protection lasts up to 3 years. And the failure rate is 1 out of 2,000, so it has got the least failure rate. 1 out of 2,000. And side effect is intermenstrual bleeding. And then comes the Mirena coil, which is an intrauterine device, works by mechanical and hormonal block, and it also helps with dysmenorrhea, that is painful menstruation, and also with fibroids. So it helps to decrease, or it helps with the fibroids, because sometimes the fibroids may bleed, or their size gets increased. So it prevents fibroids from getting increased in size. And side effect is that ectopic pregnancy could occur in its presence, or because it does not allow this fertilized ovum to be implanted in the uterus. So ectopic pregnancy can occur. It could occur even in the fallopian tubes, or it can be within the ampulla, or either it could drop out into the abdomen as well. And pelvic inflammatory disease. And protection is up to 5 years. It has got a failure rate of 2 out of 1,000. And intrauterine copper device, it is also we call as copper T. Everybody might be knowing about it. It's a very commonly used device, copper T. So intrauterine device, it basically works by mechanical blocking, and side effect is ectopic pregnancy, pelvic inflammatory disease, dysmenorrhea, uterine perforation, and menorrhagia. And protection is up to 5 years, and failure rate is 8 out of 10. And then we have got permanent contraception, which is female sterilization, that is we call as bilateral tubular ligation, BTL, bilateral tubular ligation. And or either they could go for other methods of sterilization as well, such as if there is fibroids or something. So if they've got heavy menstrual bleeding, or they are hysterectomy could be another option. But most of the times contraceptive method used, surgical contraceptive or permanent contraceptive method used is BTL, bilateral tubal ligation. and its failure rate is 1 in 200. So it is very much high. So you need to discuss those options with that female, and then you need to tell that, okay, in your case, um, since you have got DVT, so combined oral contraceptive pills won't be a good option. Instead, you could go for progesterone only pills, and you can prescribe progesterone only pills here. And what you can do is you can discuss all the options. You need to discuss, rather, you need to discuss all the options. She would say, doctor, I would like to know the chances of failure, or also I would like to know what are the complications, what are the benefits, what are the risks associated with it. So you need to memorize them so that you should be able to explain them. You have to explain, okay? Rest of the history would be same, and you will be prescribing contraceptive, uh, progesterone only contraceptive pills to this patient, okay? And then uh, let's move on to the next approach. Anybody has any question so far? All right, so let's see. Approach to LGBT scenarios. LGBT stands for lesbian, gay, bisexual, transgender, and also sometimes there's a Q, which means questioning. Okay, they are still unsure that what they want to, or what is their sexual orientation. Okay, so you need to start with grips, and your approach should be supportive. Okay, if under 18 years of age, if a minor comes to you, you need to offer confidentiality. Keep it in mind, bear in mind, whenever that somebody comes to you in asking for contraception, and she's a minor, and whether LGBT, you need to offer confidentiality. You need to offer confidentiality. Okay, and then you ask about presenting complaint, that, okay, what is the problem, how can I help you today, could you please tell me how can I help you today. And it may be a personal problem or a medical problem. Okay, and if it is a medical problem, that's fine, then you can continue taking medical history. But if it's a personal problem, you need to offer confidentiality, because the patient might not open up unless you offer confidentiality, unless they feel safe, that, okay, whatever I tell this doctor, will it remain between us, or will he be informing my parents, or will he be informing my boss or someone else. Okay, so you need to offer confidentiality if it's a personal problem. Okay, then you can say that, okay, please tell me more about your personal problem. And they might tell you, the doctor, for example, personal problem might be, they tell you, doctor, I want to become a boy, or doctor, I like a boy in my class. A boy might come to you and say, doctor, I like a boy in my class. And you will be asking, okay, I need to ask you a few more questions to have a better understanding about your problem. Okay, can we discuss more about it? Let's discuss more in detail about it. So I need to ask you a few more questions. Is that okay with you? Okay, and then you are presenting complaint has been that is either a medical or a personal problem. And then background history. You need to ask this background history, that, okay, are you biologically male or female? Do you feel uncomfortable in your gender? How long have you been feeling uncomfortable in your gender? And have you ever thought of changing your gender? You need to ask those questions. Okay, whenever somebody has come to you asking for a gender change, okay, doctor, I want to become a boy, you need to ask about background history. You will be asking, okay, tell me, are you biologically male or female? Do you feel uncomfortable in your gender? How long have you been feeling like this? Have you ever thought of changing your gender? These 4 questions must be on your fingertips. You must ask those 4 questions. Okay. And then you need to ask about sexual orientation and sexual relationship. Never ask for sexual preference. Ask for sexual orientation. Okay. So, are you sexually active? How long have you been sexually active? have you been sexually active before? If, for example, if a lesbian has come to you and she says, no, doctor, I'm not sexually active. So I'm not sexually active with the male partner. So you can say that, okay, whether have you ever been sexually active with a male partner before? Okay, you can ask it. We will be discussing scenarios over it. That's why I'm explaining it to you details. And is your partner male or female? Generally, do you tend to have sexual intercourse with male or female partners? Okay, you need to ask about sexual orientations and relationship history. And then you need to ask for support history. Support history, that okay, ask about family, ask about friends, and ask about LGBT groups. Okay, and you need to ask that, okay, who do you live with? Have you told your parents about this? How would they feel if they come to know? And how would they react if you were to tell them about this? Okay, and do you have any close friends? And have you told any of your friends about this? And have you ever been to any LGBT groups? So you need to ask about support. And then the social challenges. Ask about social challenges or difficulties. That, okay, tell me, do you face any difficulty in your day-to-day life as a result of your sexual orientation or your gender? Okay, or have you ever faced any discrimination as a result of your gender or sexual orientation? Ask about any difficulty, that have you ever faced any difficulty or any discrimination based on your gender or sexual orientation? Because there are scenarios of workplace harassment. So you need to ask those things. It might give the patient anxiety or depression. The patient might get depressed with those things, or people talking bad about them, or talking that they are, sometimes they talk that, okay, he's gay, or she's a lesbian, or whatever they say. So it gives depression or anxiety to the patient. So then you need to ask about treatment history. That, okay, for example, somebody has come to you and they want to change their gender and ask for changing their gender. Then you would ask them, okay, have you seen any doctor so far about changing your gender? Have you seen any doctor? Have you started any sort of treatment for sex change? And have you been referred to gender identity clinic? Okay, and patient might tell you, yes, doctor, I have been started on this testosterone. I've been started on testosterone. So she might be a female wanting to change her gender to male, and then she might have been seeing a doctor, and the doctor might have given them or prescribed them testosterone. Okay, and then you need to ask, okay, who prescribed the medication? How long have you been taking this medication? Where did you get this medication? Okay, do you take it regularly? Then ask all those questions related to the medication. And then you need to ask about mental health history. That, do you have any mental health problems? Okay, for example, do you have any sort of anxiety or depression, as I already discussed it? And then you need to take this history, past medical history, medication history, allergy history, and this is you need to ask about family history. Okay, any previous hospitalization, family history, diet, exercise, so smoking, alcohol, and any recreational drug use. Okay, you need to ask all those things. You can take a quick history. Where applicable, you need to ask it. Okay, because these are counseling scenarios, so you need to be quick, because you need to address some of the concerns of the patient. If you would waste your time in asking a detailed, very long history, so it won't give you any marks. These scenarios are designed in this way, that you should be able to take a quick history. It should be a sort of dialogue. It shouldn't be a monologue that you are asking questions and questions and questions and you are explaining all the way. No, it should be, you should involve the patient, and you should be asking. That you ask a question, patient answers, or patient asks a question, you answer that question. And you can ask in between, you can ask medical history as well. Okay, when necessary, you need to explore. For example, if somebody is taking testosterone, you need to ask, okay, how long have you been taking it? Who prescribed it? Where did you get this medication? Did you take it yourself or did the doctor prescribe it? You need to ask it. And then you need to ask for effects. How has this affected the patient's life? That can you tell me that how has this affected your life, or would you say that this has an impact over your life? Does this cause you anxiety? Or patient might say, yes doctor, it causes me anxiety. And then you can ask, okay, could you please tell me what kind of symptoms do you get, and what time do you normally get those symptoms? The patient might tell you, doctor, the time when I'm going to work or the time I'm going to office, I get those symptoms. Okay, and then uh, you need to examine the patient. Examination will be done only if presenting complaint is a medical problem, if they've got a medical condition. Okay, for example, they have somebody has come to you, and transgender has come to you with nasal bleed, okay, or with headache. So it's sort of medical history. You need to take medical history over here, and you will be doing the examinations. And then uh, management. Okay, management is that if they are less than 18 years old, refer them to mental health team, that is child and adolescent mental health services. Remember this name, rather cram it. Okay, this is CAMHS, child and adolescent mental health services, who after assessing the patient will refer them to gender identity clinic. Okay, gender identity clinic. First, you need to refer them to CAMHS. They will refer further to gender identity clinic. What they will do? They will do child and adolescent. Now, a question arises. Somebody would say that, okay, why are we going to refer them to mental health services? What is their role? What's their need? So, you need to tell the patient. The patient might ask you this question that, okay, doctor, what would they do for me? Why are you sending me to child and adolescent mental health services? Why? So then you will tell them that, okay, we are going to refer you to them because they would rule out any medical conditions or any mental health issues or anything that causes you, or they to exclude any mental health issue which is giving you this uh, thought that you are uncomfortable, or which is making you uncomfortable in your gender, to rule out that whether you have any medical mental issue that needs treatment. So after ruling out that you do not have any mental health issues that is making you uncomfortable in your body, so once they have ruled it out, they would be referring you to gender identity clinic. And then the next question might be, okay, what gender identity clinic is going to do for me? Then you need to explain that, okay, uh, after you have been referred to gender identity clinic, what they will do, they will after their assessment, okay, they will they will discuss various options with you, whether you want to change your gender, or whether you want to be remain or you want to retain your gender. So they will discuss the options with you. They will help you develop appropriate voice. They will help you undergo complete gender transformation. For example, from female to male, you will be undergoing surgical options. They will start you on treatment such as testosterone, and you might need to undergo organ treatments, for example surgical treatment, including uh, uh, removal of the female organs, female genitalia and breasts as well. Okay, and uh, uh, surgically development of a male genital organ. Okay, and they might help you develop appropriate tone of the voice, and so that it should match your gender. They will help you in that. So you need to refer them to gender identity clinic. After CMHS has assessed them, they will be referring them to gender identity clinic. And then you need to tell them about support, that okay, support is available. So there are certain groups such as broken rainbow. Okay, you should remember this name, broken rainbow. You need to remember this name, because it is an organization that is working for LGBT groups, and you need to refer the patient to this group, and the patient might ask you, okay doctor, what is this group, or what are they going to do for me? Then you can tell them that, okay, there you might meet people with similar problems. They come and they discuss their problems, so you might find it helpful. So you may find support for yourself from those groups. So one such group is Broken Rainbow. Okay. And then what else is that ask them to discuss with the family and friends. Okay, any close friend, discuss them, explain that discussing with your family or your friends, because you need support. So this is something it should be discussed with, you need to tell your parents about it. Yeah, okay, it's Broken Rainbow. Okay, it's an LGBT group named as Broken Rainbow. Broken Rainbow. Rainbow. Okay. It is Broken Rainbow. It is an LGBT group. It's an organization that is working for LGBT groups. Okay. There they can find support. Got it? Okay, good. So explain about Equality Act 2010 or 2010. Okay. You can tell them that just a second. Okay, got it. Fine. So you need to explain about Equality Act 2010 in all those scenarios, and that no one should be, you should tell them that, okay, there is a law that protects you against this. And according to this law, whether you know or not, let me tell you this, that according to Equality Act 2010, no one should be discriminated based on their gender or sexual orientation. If this happens, there is help available. Equality Act 2010 prevents anyone to be discriminated based on their gender or sexual orientation. Okay, you can explain it in your own words, that there is help available. There is a law that protects you against this sort of abuse or this discrimination. This law is called Equality Act 2010, which states that nobody should be discriminated based on their gender or sexual orientation. Okay, and then you need to offer leaflets about LGBT groups like Broken Rainbow. Okay, here it is, Broken Rainbow, and offer leaflets for gender identity clinic as well. So this is the approach. You need to approach the scenario in this way. You should remember it, that you will be starting with grips. Your approach should be supportive and sensitive approach, and presenting complaint could be personal or medical, background history, ask for questions here. Okay, sexual orientation and relationship history, support history, family and friends, social challenges, any difficulties or any discrimination in daily life, and treatment history, any sort of medical treatment or any other treatment they are taking, mental health history, particularly ask about anxiety or depression, and then go for quick this past medical and medicines and allergy history. And also you need to ask for any effects that the patient has on his life, or any impacts, that how has this affected them, and examination in case of medical issue. And then management. The key over here is that you refer them to child and adolescent mental health services, who will refer them further to gender identity clinic, but you won't directly refer them to gender identity clinic. But if it's someone elderly, someone who is more than 18 years old, they come to you, so then you can refer them to adolescent mental health services. Okay, adolescent mental health services, and then they will refer them to gender identity clinic. And then refer to LGBT groups, discuss with family, explain about Equality Act, and offer leaflets. This is the entire approach for LGBT groups. So let's have a look at a scenario, typical scenario, that You are FY2 in GP surgery, 16 years old, has presented with some concerns. Talk to her and address her concerns. Okay. So let me tell you that this is a patient. She has come to you and she would be saying that, doctor, I have a personal problem. So when she mentions, okay, I have a personal problem, okay, all right, it should come to your mind that, okay, she has a personal problem. So offer confidentiality. And she would say, doctor, I want to change my gender. I want to change my sex. I want to become a boy. And then you have got it. Because from the scenario, these scenario present like this in PLAB 2 examination as well. They present like this, that a short statement would be given and you won't get an idea what's going on unless you go and start the conversation. Or sometimes a confusing name, two confusing names, male and a female name might be given in the scenario, and then you might get confused and you might get an idea that, okay, what's going on. And when the patient has ordered, asked you, or the patient has told you that, doctor, I have a personal problem, offer confidentiality, and then you need to uh, continue this approach. The above, you have to continue this above approach. That okay, tell me more about it. Are you biologically male or female? Take background history. Take background history. Are you biologically male or female? Do you feel uncomfortable in your gender? Okay, how long have you been feeling like that? Have you ever tried to change it before? Or is it your first time presenting over here? And then you can ask for sexual orientation. Have you ever been in a sexual relationship? How long have you been? And is your partner male or female? Generally, do you tend to have sex with men or women? Okay, male or female? And ask about support history, social challenges, support history, social challenges, treatment history, mental health, effect of situation on patient's life, examination. And here we won't be doing any examinations because it's a personal problem, it's not a medical issue. So uh, she might tell you that, okay, doctor, I want to change my gender. And then you will be taking, and then what you will do is you will be referring the patient to child and adolescent mental health services. Okay. And then you will once it has been she has been referred to CMHS, they will further after their assessment they will refer you to gender identity clinic. The patient might ask you that, okay, doctor, what are they going to do for me? Then you need to say that, okay, they will help you understand what is happening within your body and why you feel this way. And following the assessment, you would be having an option either to change your gender or keep your gender. And or you if you want to change your gender, then you would be undergoing full gender treatment, which includes hormonal treatment such as testosterone. Because you are female, you want to become a male, so they will be giving you male hormones, testosterone. And if it is a male wants to undergo transformation to female, then they will be giving estrogen. And there will be a multidisciplinary team who will see you, and which includes speech and language therapists who will help you develop appropriate tone of voice to match your gender. And also you will be seen by the psychologist as well. And other treatment as surgery, as I mentioned before. Okay. And then you need to refer her to LGBT groups. You should tell them that, okay, it is important for you to have support. So we have got, there are certain organizations where the support is available. These are LGBT groups. One such name is Broken Rainbow. And here you can meet people who have been through the same experience, and they would be sharing their experience in that groups. And then you need to discuss discuss it with your family and friends. And then explain about Gender Equality Act 2010, and offer leaflets about LGBT groups. And then tell them that, okay, there is this Broken Rainbow, and offer leaflets about gender identity clinic. But since she is um, less than 18, so you will be referring her to CAMHS, and then they will refer to You can just give them idea. You can tell them that what would happen to you if you go there. Okay, what CMHS would do and what GIC would do. Okay, and then this is the same approach. And next scenario is culturally committed bisexual scenario. Okay, so you are FY2 in GP surgery, 16 years old, has made an appointment to see you and talk to him and address his concerns. So he is a male. You have got an idea from his concerns. Talk to him and address his concerns. And then what you will be doing, you will be following the same approach. Here the patient has come to you. The patient would be saying, the doctor, I am here to talk to you about personal problem. And then you would say that, okay, you have made the right decision. I'm here to help you. And whatever we discuss here would remain between us. Please go on and tell me more about your personal problem. Okay. So doctor, I like a boy in my class. I have feelings for another boy in my class. I'm a bit worried about it. And then he might tell you that, doctor, I was in a relationship with a girl before, but I didn't like it. So is it normal for somebody or some boy to have feeling for another boy? So, and I haven't told anybody about this. And then here where your IPS comes in and you would say that, okay, you have just made the right decision. I appreciate that you are here to discuss with me, and I'm here. I'm sure that will definitely help you in this regard. So please go on and tell me. And he might tell you everything after he has told you, and then you should ask that, okay, I need to ask you a few more questions to have a better understanding. Then you will be asking about all the same approach, that background, ask about sexual orientation, ask about support, and ask about any challenges, any difficulties, and ask about this treatment history, mental health history, and then effects of situation. And then what the management in this case would be that this, since he has come, so you would tell him that, okay, you won't be referring him anywhere at the moment. You would just be telling him that, okay, it is your personal choice in terms of who you want to be in a relationship with. There is no right or wrong thing to do. Okay, and why don't you talk to your friend and see if this works for you? Okay, you should convince him to go and ask you and talk to his friend about his feelings, whether it works for him or not. And then, or ask him that whether this is the relation you would like to continue with him, and it is better to talk to your friend about this. Okay, and then you need to explain Equality Act 2010, and ask them to discuss it with the family and any other close friend as well. Okay, if he has got a close friend who he feels comfortable to discuss with, and refer to LGBT group, give information about broken rainbow, and also uh, just to check on him, how is he doing, just have a follow-up within 2 weeks time. Okay, to see that how things are ongoing. Okay, this is all the management for this scenario. So you have to basically, it's a problem that he is confused, that, okay, he has feelings for another boy. So you need to convince him that, okay, first you should go and talk to your friend, that how he reacts, what does he say. So you need to talk to him. Okay, and then we have another scenario that we have chest pain in transgender. FY2 in GP surgery, Michael, 30 years old, who likes to go by the name Michelle, has presented with chest pain. Talk to him and address the concerns. Okay, so I told you that there might be confusing names. So one of the names is male and other is a female name, Michael and Michelle. So you might get an idea from here that, okay, what's going on? It is LGBT scenario, one of the LGBT scenario. So you might not know until later, or you might be knowing from the name, but sometimes you might not know until later when the patient, when you start asking about any medication history, when you start with PMMA history, that okay, past medical, any medication, any allergy, any family history. And when you will be asking that history, then you might come to know that okay, it's an LGBT scenario. Then LGBT history would begin over there. Okay, so the presenting complaint is a medical problem presented with chest pain. So chest pain is a medical problem, so you need to take medical history. Okay, how can I help you? And then you need to go for side that acronym that Dr. Ahmed has already discussed with you in detail, that STOOPPAKRS. You need to do that for chest pain, what is the side, what is the type of pain, onset, okay, and aggravating relieving factors, and when did it start, what were you doing when the pain started, and okay, has this type of pain occurred before, could you please score this pain for me, and have you tried anything so far for it? Has it been increasing or decreasing, or has it been the same? Okay, so you have got that mnemonic or acronym, you can say. You can take history, medical history. You would be taking medical history in the same way. Okay, and then you need to rule out DDs like pulmonary embolism, pneumonia, and MI. And then ask for pain in lower legs as well, to exclude any DVT or pulmonary embolism. You need to ask it, and you would be quickly going through this past medical history, medication, allergy, any hospitalization, any family history, diet, exercise, smoking, stress, and alcohol. Okay, and then treatment. When you will be asking the patient about any medications history, any medication history. Okay, the patient here is the patient would say, the doctor, I am taking estrogen and spironolactone. And then here your mind clicks. Okay, so this is this, the patient is taking estrogen. And then you might ask, okay, can you please tell me that why are you taking these medication, how long have you been taking, and who prescribed those medications? Okay, they would tell you, the doctor, I've been I've been undergoing treatment for gender transformation, so my doctor prescribed it, so I need to take these medications. And then here your transgender history begins, and you need to ask, you will be going for quick, you need to quickly ask all those things. Okay, and how long have you been taking this treatment? Are you regularly following up with your doctor? And okay, so then what you will be doing after you've taken transgender history, what you will be doing is you will be going for examination, because I mentioned earlier that whenever it is a medical problem, you need to go for examination. If it's a personal problem, no need for examination. Okay, there won't be anything because related to medicine or medical issue, so you won't be, examination won't be fruitful, or it would be of no use, no need of doing examination. So you will be doing checking observations, including blood pressure, pulse, temperature, oxygen, breathing, and also you will be doing respiratory examination, cardiovascular examination, and you might examine the lower limbs to see for any swellings or any tenderness on the calf to rule out DVT, and you might run ECG. Okay, you would be just mentioning the examination, and the examiner might say, okay, everything is normal. And then he might tell you some findings on the ECG, that okay, ECG shows this pattern, this particular pattern, S1 Q3 T3, so it is consistent with pulmonary embolism. So chest pain, because the patient has been taking estrogen and spironolactone. Estrogen is it increases, it forms, or it can cause a hypercoagulable state in the body. Okay, hypercoagulable state in the body. So it can lead to DVT and then PE. So what you will be doing, you will be explaining the diagnosis to the patient, that okay, from what you have told me and from what we have discussed so far, and after doing the examinations, keeping both the history findings and the examination findings together. So what I suspect, or my provisional diagnosis, that you might be having a condition called pulmonary embolism with DVT, with or without DVT, whatever it is. Okay, pulmonary embolism. So you know what it is? So it is a condition in which clots are formed within the legs, and then they move towards the lung and block the supply of blood to the heart or lungs. Okay, and it's a potentially dangerous condition, and the reason for it is that the medication, in your case, the reason for it could be the medication, that is estrogen, that you're taking for your gender change. And then management is that you have to refer the patient, because he has presented to you in GP surgery. So you need to refer the patient urgently, rather immediately, to this hospital, and you need to admit the patient under medical team. Okay, you can arrange this. You need to arrange the transport for the patient as well. Okay, an ambulance or transport, because it's a potentially dangerous condition. So you have to stop. What you will be doing, you will have to tell the patient to stop the treatment, but they might be reluctant. Okay, doctor, if I'm going to stop this treatment, it is important for me. Don't you know how important it is for me to undergo sex change? So you will be telling that, okay, we understand, I understand that how important this is for you, but at the moment, you are having a potentially dangerous condition. We need to stop those medication right away and start treatment with another type of medications that are blood thinners, and we will be restarting these medications once we have discussed it with your consultant, or the person or the doctor who has prescribed this medication to you. Okay, this is all management in this case. Similarly, another scenario is testosterone side effects in a transgender. You are FY2 in GP surgery, 21 years old female made an appointment to see you. Talk to her and address her concerns. Okay, these scenarios are very important scenarios, because these scenarios are they are a routine scenario. They are the routine scenarios which come in PLAB 2 exams. Okay, so you must know the approach. If you know the approach, the approach is the key. Like you know the approach, and you can if any difficult scenario or any unusual scenario comes in the exam, you can pass that station. Okay, because you would be having background knowledge or approach in your mind, so it would be easier for you. And okay, you are FY2 in GP surgery, 21 years of female, made an appointment to see you. Talk to her and address her concerns. So here are testosterone side effects. Let me tell you that this is a patient who has nasal bleed, and she's been having headache for the past 7 days, 5 episodes of nasal bleed as well, and she has been having this constant dull pain in his head, and she has been undergoing she has been taking testosterone, but you won't find it earlier. When you will be discussing, when you will be reaching this medication history, she would tell you that, doctor, I'm taking testosterone. And then you will ask that, okay, who prescribed it? And this is the patient who has already been to gender identity clinic. She had an appointment with her consultant, and consultant sorry, she has an appointment with her consultant, but it has been taking very long for her. So she has been waiting for the appointment, and she has ordered this testosterone online. And she has online ordered this testosterone and started taking this medication herself. Okay, she hasn't seen the consultant yet. She has got the appointment, but she has not had any meeting with the consultant yet. So she has uh, started this treatment on her own. Okay, so The approach would be the same, that take history for medical condition, and then history of presenting complaint, take history for headache. If she's having headache or nasal bleed, you need to take history and ask for ask for how many episodes were there, any bleeding uh, any bleeding in stool or blood, any bruising over any other part of the body, any bleeding from any other part of the body, for example, ear, mouth, okay, and any other orifices, you can ask that. And then you need to continue with this PMMA, uh, HO, and family history, and DESA, RS, totally. You need to go for all that history. When you will be asking about past medication history or medication history, the patient might tell you, the doctor, I have been taking testosterone. Then here you will be asking that, okay, why are you taking testosterone? Who prescribed it? How long have you been taking it? The patient, here the transgender history will begin. The patient might tell you, the doctor, okay, I want to change my gender, and I've been undergoing sex transformation or sex change. So you would be asking, okay, have you been to gender identity clinic? Have you seen the consultant? And then you need to examine the patient, take transgender history, and she would tell you, the doctor, no, I have already got the appointment, but I haven't seen the consultant yet. I was so curious to start the treatment that I ordered it online, and I started it myself. And then you will be doing the examination, go for check observation, including blood pressure, pulse, temperature, oxygen, breathing, and go for ENT examination, because it's a nasal bleed. You need to see whether she has had any injury, nasal injury, or was it epistaxis, okay, or was it spontaneous bleeding, was due to testosterone. So most likely it was due to testosterone. So you need to go for ENT examination, head to toe examination, to look for any bruising, any abnormal marks, any discoloration over the body. Okay. And then neurological examination, you have to do it, because she's complaining headache. It could be subarachnoid headache. She might have got this subarachnoid hemorrhage. So it could be possibility. You never know, because it increases the incidence of bleeding, and it's one of the side effect of testosterone. It causes headache, and somebody on testosterone complaining of headache, so you can think of serious consequences or serious diagnosis. Okay. And you need to tell that, okay, I've examined you, what you have told me, and all that, keeping all that in mind. And examination, it seems that this is because of the effect of testosterone, because testosterone can cause high blood pressure, and which can cause nasal bleeds, and also it can cause headache, and sometimes that high blood pressure can even result in bursting of the blood vessels as well. So that's the reason. Testosterone can increase blood pressure, so that's why she had nasal bleed, and you have to stop taking the testosterone. And then she will be telling, doctor, I have appointment, but it's very late, I cannot wait for so long. So then you will be telling that, okay, I will try to bring your appointment close. Would that be something you would like me to do? Because what I can do is that I can call your consultant, and I can ask them or request them to bring the appointment to a near date, okay, or reschedule your appointment. And then you will be prescribing painkillers for headache. And if she has nasal bleed in future, you need to tell them that what did they need to do. You should tell them that you need to come to the hospital immediately. Okay. This is the management for testosterone side effects. Basically, we are going through medical managements, because these are medical scenarios. So we are going through and then next scenario is FY2 in UTI in a transgender. Your FY2 in GP surgery. 20 years old female has come with urinary symptoms. Talk to her and address her concerns. And the scenario B would be in this case, the patient would tell you that, doctor, I feel uncomfortable, or I'm not comfortable using public toilets. Then when she will be telling you this, your mind would click that, okay, it might be a case of LGBT. And then she will tell you, doctor, I feel uncomfortable because I am a transgender, or they might tell you that I feel uncomfortable. Okay. And then in the next scenario, she might tell you that, doctor, I have PCOS, that is polycystic ovarian syndrome. So the approach to both the scenarios is similar. What you will do is you will be taking the history of the presenting complaints and ruling out DDs such as UTI, STI, pyelonephritis, and renal stones. And you have to complete your PMA, Holy Family, Desatoli, that history, medical history, and go for ICE, that is ideas, concern, expectation. And when you will be discussing until late, whenever when you reach ICE, okay, here you can see the importance of ICE, that when you will be reaching ICE part, you would say that, okay, do you think there could be anything that might be the cause of your condition or your symptoms? Then she might tell you that, doctor, I don't know, but maybe it could be due to the thing that I hold urine for longer times. I do not urinate frequently. Here comes to your mind. Okay, then you explore the reason why. Any particular reason why you do not urinate frequently? And then she might tell you, no, doctor, I'm not comfortable using female toilets, okay, or male toilets. And she's a female, so she would say, I'm not comfortable using female toilets. And you would ask any particular reason why you are not comfortable. And then she would tell you, doctor, I think myself is a male. I'm not comfortable in my body. And then your transgender history begins here. And you will go with transgender history quickly, and then again go for examination, check observation, blood pressure, pulse, temperature, oxygen, breathing, and check temperature. The temperature, when you are checking, it might be high, or abdominal exam might reveal suprapubic tenderness. Okay. And urine dipstick test, because it's a bedside test, you can order for it to rule out UTI, and nitrates might be positive in that, so they suggest UTI. And management would be, you would be prescribing antibiotics, that is trimethoprim. You can just say simply, okay, we will be prescribing you some antibiotics which you need to take for 3 days. Give some antipyretic for fever relief, or if she has pain, give some painkiller as well. Paracetamol would work fine in both pain and fever. Okay. And then what you need to do is you need to take urine for culture to find out which bug caused the infection. And if it responds, to tell the patient that, okay, if it responds to the treatment, that's pretty much fine. But if it doesn't, then we would be changing the antibiotic after culture report. And what you need to tell them, give them advice that, okay, avoid holding urine longer periods of time. And you also need to drink plenty of fluids. And one simple tip is that always after urination, try to wipe yourself from front to back. In this way, you can prevent UTI. You can minimize the risk of UTI. And she might ask you the reason, the doctor, why did I get this infection? And you should be able to tell that, okay, it's a general knowledge, like holding the urine for longer periods of time, stasis of the urine uh, causes infection because it stays in the bladder. It can become infected. So that's why you have got this urinary tract infection. And then scenario B is PCOS scenario. The patient says that, okay, doctor, why did I get this infection? You can tell that PCOS can sometimes can cause high blood sugar, and high blood sugar can cause UTI. Okay. High blood sugar can cause UTI because sometimes sugar starts appearing in the urine, and this is a good medium for bacterial growth or growth of microorganism. So you might have got this. Okay, everything will be the same as in the above scenario. And you need to tell her that, okay, female gender itself is a risk factor for UTI. So UTI in a transgender and PCOS. So the next is lesbian who wants referral to NHS fertility clinic. Okay. She is FY, you are FY2 in GP. She has come to you, 36 years old female, has made an appointment to see you, talk to her and address her concerns. Okay, address her concerns. All right. So let me tell you that this patient has come to you and she wants referral to NHS fertility clinic. She has been married for the last 7 years, but her partner is a female because she is a lesbian. So her partner is a female. She is not in a relationship with any male for the last 7 years, and she wants to have a baby. And she has never been pregnant before. So I told you that she has never been in a relationship with a man. She never had this relationship. Okay, so this is the background knowledge. So now let's see what how to approach this station. What you will be doing, you will be starting with the grips and greet, respond, introduce yourself, purpose, and paraphrase, and then smile, and then start the station. Okay, how can I help you today? So she would say, doctor, I want to be referred to NHS fertility clinic. You can say, okay, can I ask you a few questions to have a better understanding that whether referring you or that why you need referral to the NHS fertility clinic, or whether referring you to the NHS fertility clinic would be a better option. You can ask either way. And take history. Start taking the history that, okay, have you ever tried to get pregnant before? How long have you been trying? And then ask about sexual history. Is your partner male or female? Have you ever had a male partner? Okay, how long have you been trying to get pregnant? So she would say, I've never had a male partner. And then you need to take out this menstrual history, ask about menstrual history, ask about any past medication, past medical illness, any allergies, any hospitalization history, family history, go for social history, diet, exercise, the smoking, stress, alcohol, okay, any recreational drug use, and any sleep problems, and you need to rule out all those things. You need to ask about those history and then go for examinations to see everything is normal, to examine that she is fit and well, then check her observations and check her BMI, go for a tummy examination, and you can also run some routine blood tests as well. Okay, and then you need to explain to the patient that, okay, unfortunately, because you are in the same sex relationship, okay, you do not have to say over here, you do not need to be judgmental. Never ever be judgmental over here. If you would say, it is understood, it is confirmed, she has told you that, doctor, I'm a lesbian, but you won't say that since you mentioned that you are a lesbian. No, no, that's wrong. That doesn't sound good. You would say, rather, you can say it in a very nice and polite way that, okay, unfortunately, because you mentioned, or unfortunately, you are in the same sex relationship, you currently do not meet the criteria to be referred to NHS fertility clinic. You need to try at least 6 times before you could be eligible to be sent or to be referred to NHS fertility clinic. But I can tell you, or here are here are some options that you could try to get pregnant. Okay, so would you like me to discuss them for you? She would say, okay, doctor, tell me the options. So you would be telling that, okay, the very first option, or the first option we have, is you can try it on your own. And that what you can do is you can find a sperm donor. That can be someone you know or you do not know, and you can take sperm from that donor and you can inject yourself with that sperm at home. This is called self-insemination. Okay, you can try self-insemination at home. This is an option for you. Number one, this could be an option for you. Number two, some women prefer to have sex with men despite being in the same sex relationship to have children, but that won't be a suitable option for you. Okay, because she has never had a male partner. So you can mention it that, okay, it won't be suitable option for you. And then third option is that you can go to private fertility clinic. And same time you have to tell that, okay, you can go to private fertility clinic, but it can be quite expensive. And then you ask that, okay, which one of the above options do you think would be more appropriate for you? You need to ask, and then you would say that I'm really sorry, I could not refer you to NHS fertility clinic today because you do not meet the criteria. So that's all about this scenario. Now let's go to another scenario. Depression in lesbian. 32 years old female has presented to the GP surgery with some concerns. Talk to her and address her concerns. Okay. So let me tell you the background history that she has been having low mood. This lady has presented to you and she has been having low mood. The reason being is that her partner, who is a female, had 2 miscarriages in the past. And because they've been trying for the baby for the last 2 years, and she had miscarriages twice, so she is feeling low mood, and this low mood has affected her work. And also she has lack of sleep, and normally she used to sleep at 10 p.m. and she used to get up at 8 a.m. But these days her sleep has been disturbed and she gets up normally at 5 or 4:30 a.m. Okay. And her partner was also sad in the beginning because of the miscarriage, but she's now okay. Okay. So it's depression. So you know how to take the history of depression. Let me tell you that this is because her work, she would say that, doctor, my work has been affected, my mood is low, my work has been affected. And when work is affected, so it comes when, if it affects your daily life activities, including the work, with low mood, work is affected, so it comes under moderate depression. So what we would do is, we would normally follow that approach. We would refer her for counseling, and we would start her on antidepressant medications as well. Okay. We would refer for talking therapy, and antidepressant medication would be given. So approach would be the depression approach. Do grips and ask for any significant event that has happened. She won't be telling you, okay, could you please tell me how can I help you today? She would say, the doctor, I am feeling sad, or I have low moods. Then she says low moods, then you start taking the history of depression. Take psychiatric history, take medication, mental health problems history, and she would be telling you, doctor, my partner had miscarriage. Ask about, sympathize with her, that, okay, I'm really sorry to hear about that. So how is your partner doing now? And does she have the low mood? Does she have low mood as well? Okay. And what you need to do is, you have to take this whole history for depression, take depression history. And after that, what you would be doing is, the management would be, she's having moderate depression, we will be starting on antidepressants and CBT. So she would ask that, doctor, what about antidepressants? How do they work? How does this medication work for me? So you would say that, okay, this medication belongs to a group of medication we call as SSRIs, that is selective serotonin reuptake inhibitors, which blocks a chemical in the brain called serotonin. Okay. And it blocks this hormone, and it improves your mood. It helps with low mood. Okay. And reassure about the partner that just because your partner had miscarriage twice, it does not mean that it will happen again. There are same chances for your partner to become pregnant again as for any other normal female who did not have miscarriage. Okay. And but if she suffers a third miscarriage, then she needs to come, and we will perform some investigations to rule out any cause for miscarriages. Okay. So this is the management for this scenario. So the idea behind this scenario was to give you idea was that this is a moderate depression because the work has been affected. She has low mood, work has been affected, and she needs medication plus CBT. And you need to reassure for the partner as well that okay, it would be okay, it's fine, she can become pregnant again. It's not like that she had 2 miscarriages and third would be again a miscarriage. No, she has equal chance of becoming pregnant and continuing a normal pregnancy as any other female who never had a miscarriage. Okay, but that risk becomes more, or she needs investigation after the third miscarriage if it happens. Okay, and then the next scenario is harassment at workplace. Harassment at workplace. So you are FY2 in GP surgery, 20 years old, female has made an appointment to see you, talk to her and address her concerns. Okay, so patient would come to you. Basically, she is being harassed because she is a lesbian and she has started in office recently, and people talk about her, or her other co-workers talk about her that she's a lesbian. So she is upset and she has come to you, and she feels uncomfortable in talking to, or she's not comfortable in talking or complaining to her boss. So what you will be doing, you will be addressing her concerns today. So let's see what, and she has started because of this low mood, she has started drinking alcohol, and she drinks 2 bottles of wine every day. She has started drinking heavily, and her family members know about her that she's a lesbian, and she has got this harassment gives her stress at work, and she gets palpitations. Okay, so she would come to you and she would say that doctor, approach would be, or how you approach this session, you would be starting with the grips, take history of the presenting complaint. Patient would say the doctor, I need some advice, my colleagues are saying bad things about me. Then you would ask that, okay, I'm sure I can help you with that, but could you please tell me more about it? What kind of things do they say? And when did they start talking about bad? She would say, the doctor, they have started talking bad about me. Then you would say that, okay, when did they start talking bad about you? Do you talk to them, or have you talked to them that how you feel about it? Have you thought of talking to your manager? Have you tried talking to your manager? And what about your other colleagues? Are they okay with you, or do they do the same thing as well? Okay, and ask about her relationship. Are you in a relationship? Is your partner male or female? Could this be the reason? She would be telling you, the doctor, my partner is a female, I'm a lesbian. She would straight away say, you doctor, I'm a lesbian. Then you would say that, okay, could this be the reason that could this be the reason for your colleagues to say bad things about you, that you are in the same sex relationship? Again, avoid saying word lesbian, that you are lesbian. No, that you are in the same sex relationship. Could this be the reason for it? Have you spoken to your partner about this? How does your partner feel about it? Okay, and then ask about support, family and friends. And have you discussed with your parents? Do your parents know about it? And do you have any close friends? And did you discuss it with your friends? Okay, have you faced, ask about any discrimination, ask about any difficulty. She is already having a difficulty at workplace, you need to ask about discrimination as well. Have you ever faced any discrimination elsewhere apart from your office, okay, or your workplace? And then you need to ask for effect over the patient's life, that how has all this affected you? Does it cause you anxiety? She would say, yes, doctor. Then you would be asking, okay, what kind of symptoms do you get? She would say, doctor, I get heart racing and I get short of breath. And you would ask that, okay, when does this normally happen? Patient would say, doctor, this usually happens when I go to work. And um, you would ask that, okay, what have you done so far what have you done so far for your anxiety, for your situation? She would say, doctor, I have started drinking alcohol. And then you need to ask about her mood, any thoughts of self-harm, okay, and any recreational drug use apart from alcohol, because she's already drinking, so she might be taking, because sometimes when people are depressed or uh, they are pushed to certain level that they start taking recreational drugs, okay. And then you need to ask about this drug history, recreational drug history as well, and ask about past medical illnesses, any medications, any uh, significant history in the past, allergies, medical conditions. You need to rule out all that, okay? And then you need to explain that, be really empathetic, that, okay, I'm really sorry to hear that you are going through all this. What you are going through is harassment at workplace, and this is based on your sexual orientation, and it is something that is not acceptable, okay. And then you need to explain Equality Act. You would say that there is a law that protects you against it, and it is called Equality Act 2010. It prevents any harassment at workplace based on sexual orientation or gender. You also have the right to make a complaint to your manager. What is happening is not okay, and you have the full right to make a complaint, okay. And then you ask that, oh, okay, do you think that you'll be able to make a complaint to your manager? Are you comfortable to talk to your manager? She would say, no, doctor, I'm not comfortable to talk to my manager. So you would say that, okay, would you like me to talk to your manager on your behalf? And she would say, yes, doctor, you can. Is it something that you can do? You would say that, yes, definitely we can do. We can help you out. I appreciate that you have come here today and you have discussed it with me. And thank you for coming over here. And then you need to refer her for counseling because she's stressed. Okay, she's stressed, and you also need to tell her that, okay, unfortunately, taking alcohol will not help with your symptoms. Rather, it would cause worsening of your symptoms. So you need to, and also you are drinking more than the recommended units a week. So I would recommend you, I would suggest you to cut down on drinking. Would it be something that you can do? Okay, and then you can refer her to LGBT groups. She would say that, doctor, I've been there. And then you would ask, okay, how did you find them? Was it helpful? She would say, yes, doctor, it was fine. I enjoyed a lot, and it was a good experience because and there was similar people discussing their stories. So I usually go there, and you should tell her that, okay, you can continue going there. Okay, and also advise her to discuss with family. All right. Also advised to discuss with family. Okay. So this was all about LGBT approach. So, all right. So approach to end of life discussion. It is related to scenarios where elderly or where people who are diagnosed with terminal conditions, they refuse to take medications, and they want to stop treatment, and they do not uh, want to continue further, or they do not want to stay in the hospital. So you should know that how to approach those patients, how to deal with those patients. Sometimes the patients get convinced, and they listen to you after a small negotiation. Okay, after a certain amount of negotiation, you can convince them, and you people come to the patient, and you come to an agreement that, okay, we can stop those medications and we can continue these medications. Okay, and sometimes they are so reluctant that they do not want to continue any sort of treatment, or they do not want to stay in the hospital at all right. So let's see how do we approach it. So You need to greet the patient, will repo, introduce, paraphrase, and with a smile. Okay, smile should be there. And paraphrase, I understand you have some concerns about your treatment. What are your concerns? Okay, patient might say that, doctor, I want to stop my medication. And then ask about medications. Okay, what medications are you talking about? Are you talking about antibiotics, the painkillers? Okay, which specific medications? And what do you want to stop and why? And then they will tell you the reason. Any particular reason you don't like hospitals? If and somebody patient might tell you, the doctor, I don't like hospitals. And then you would be asking, okay, any particular reason you don't want to be in the hospital? Why don't you like the hospitals? It is because they might be having some bad experience with some relative in the past, that who was admitted in the hospital, who was terminal or admitted in the hospital, and he or she died. So it could be the reason that they do not like hospitals. Okay, and then here comes another principle. Here comes another thing that I asked you to check for: mental capacity. Okay, whenever someone refuses treatment, always ask why and then assess mental capacity. And because I told you that doctor is an advisor, he can't forcefully treat a patient. He's just an advisor. Patient's autonomy is the thing, that you have to respect patients' decision. What they are going to say, you have to assess their capacity. If they are having capacity, they are having sound mind, so they have the capacity to opt for or refuse any treatment. All right. So you can't force and treat the patient. You can't force them to have certain treatment or stay in the hospital. Okay. And assess mental capacity. Assess mental capacity ask by asking that, okay, what do you understand? There are four things, like if whether they are able to understand, whether they are able to retain the information, whether they are able to contemplate, that is to think deeply over it for certain period of time and communicate it back to you. Okay, these are the four things how we assess capacity. Okay, hope I have answered that question. There are four questions to check that whether they understand, whether they uh, whether they understand, and whether they retain the information what you have given, whether they are able to contemplate, which means that they can think over it. Okay, they give it thought for a reasonable period of time and to keep it in mind, and also they are able to communicate it back to you, that doctor, I do not want to take certain treatment. What would be the consequences if I do not take this treatment? Okay, so you need to ask about, okay, what do you know about your condition? What treatment are you getting? What the doctors have told you about it? What treatment are you getting? And why this treatment has been started? And what would happen if you do not continue this treatment? Okay, so you need to ask all those questions to check their capacity. And then, so uh, the patient, if after asking all those questions, you will be assessing that the okay, patient has the capacity and patient understands that, okay, then you will be saying, okay, so you clearly understand everything, so what is the most important thing for you? Here you need to promote the next best thing in their interest. Okay, patient could still say no, and you would be saying that, okay, what's the next best thing in you would be thinking for the patient, that okay, so you understand that stopping treatment for heart failure, for example, stopping antihypertensive medication, can cause worsening of your heart failure, and you might die of it because of the heart failure. So uh, the what is the most important thing for you at the moment? Okay, and then fill in the gaps. If they have any gaps in discussion, for example, patient might not know something. Let's say that maybe this is why you were giving the medication because you had uh, MI, or you had heart failure, you had developed pneumonia, or you had developed infection in your body. So that's why you were given certain medication. So, and explain the consequences as well. that okay, you mentioned that you get tired even after taking those medication, that the tiredness could be due to your heart failure. Okay. And if you stop the medication, the symptoms might get worse. Okay. And uh, if a patient is reluctant, for example, patient with ectopic pregnancy wants to leave the hospital, and they do not want to get admitted, so you need to explain that they could have severe bleeding, and they might not know, they may not be aware of the bleeding because it would be inside their tummy. Okay. uh, Yes, I can give an example. For example, I have already, I think, answered your question, but we will be discussing it in a scenario shortly. For example, a patient he's on chemotherapy, and now he has developed a neutropenic sepsis, and you have started him on antibiotics, and he's in the hospital. He would be saying that, I do not want to take those medications. I do not want to stay in the hospital. I do not want to take medications." And then you would be asking that, okay, what do you understand about your condition? Okay, what treatment were you given? And what would happen if you do not take the treatment? Why is this treatment necessary for you? Why you want to stop it? Okay, you can ask. So uh, the next thing is, you need to take psychosocial history. Psychosocial history means that you need to see who is in the family, who does the patient live with, and has the patient discussed this with their relative, maybe the patient's daughter or the patient's son? So has the patient discussed it with his or her daughter? Okay. And mm, does he have any chronic health issues, any stress, including financial stress, any problems with the family, and any problems with the housing? Okay. So you need to take psychosocial history. And social history is that, no, I mentioned that, who do you live with, who is in the family, have you discussed about stopping this medication, this particular treatment, with your daughter, with your son, with your wife? Okay. And patient might tell you, yes doctor, I have discussed it with my daughter, but or I haven't discussed it with her because she would stop me from doing so. Okay. So after this, you need to accept the patient's decision. Okay, patient's autonomy. That patient has already said, the doctor, I understand. This is my treatment. I understand. I know everything about it. So at the end, you will be stopping this. Stop convincing the patient more and more, and you will ultimately accept the patient's decision. Okay, and then you have to discuss a very important chapter over here, which is you need to discuss the future plans for the patient. That okay, as you have started thinking about, you have an agenda and you have to discuss it with the patient, and you have to tell the patient that, okay, Mr. Smith, it's good that you have started thinking about your future. So therefore, I believe it is the right time for us uh, to talk to you about few things regarding your treatment, or regarding decisions in terms of looking after you in future. Okay, so can I go ahead? So then there are a few things you need to discuss. You would be discussing about, this is basically advanced directive or advanced care plan, which you have to discuss with the patient, that which includes advising to have a lasting power of attorney. You would be saying that, okay, the first thing I'd like to discuss or talk to you about is appointing someone as your lasting power of attorney. Everybody knows in UK, everybody knows who is lasting power of attorney. What does advanced directive means? What does lasting power of attorney means? So it is common practice over there. So you will be asking that, okay, at the moment you are able to make your own decisions, but if your conditions gets worse, and you can become unconscious and may be confused, and you may not be able to make your own decisions, what you can do is actually you can appoint someone to make those decisions on your behalf for you. Okay. It could be anyone, it could be any one of your family members or your friends, whoever you trust would be able to help you with this. Okay. And so what do you think about appointing lasting power of attorney? If you are interested or you are in favor of appointing lasting power of attorney, you can speak to your GP. They'll complete this with some solicitor, okay? Because it's a legal document to be written, so GP and a solicitor must be there. And then go for the next thing. Tell them that, okay, the next thing I want to discuss you is with DNAR, DNA CPR or DNAR. DNA means do not attempt, CPR cardiopulmonary resuscitation, or R resuscitation. Do not attempt cardiopulmonary resuscitation. Okay. In UK, some the people have whosoever have this chains, lockets, or some batches, or some stickers, or some sort of thing. There might be people having this lockets mentioning that DNAR, which means do not attempt resuscitation. If they fell unconscious at a public place, normally the routine is that we start with this BLS, we start with chest compression, we go through this BLS. But some people have it, and if you are going to attempt it, their relatives are going to sue you. Even if you save the patient's life, they're going to sue you. Okay, so it is very important. Bear that in mind. The next thing that I would like to discuss with you is for a specific situation. If your condition gets worse, there's a possibility that you may develop cardiac arrest, which means your heart might stop working. And what we can do in those situations is we normally do is we start chest compressions. We try to restart the heart by doing so. And we call that as CPR. Do you know anything about it? Patient would say, yes, doctor, I've seen it in the movies and it's so horrible. It's so painful. I don't want to go for that. And then again, you would say that, okay, in a similar situation, if your lungs, or if you develop respiratory arrest, which means that your breathing stops. So in a similar situation, what we do is we try to pass a tube into your lungs, okay, in your windpipe, and we connect it to an external machine we call as ventilator, which takes the function of your lungs, and we call it as assisted ventilation. So the patient might also refuse it. Patient might say that, no, doctor, it is also very painful. I do not want to go for this treatment as well. Okay. So you would say that, all right. And then you have asked for asking about assisted ventilation, and then record of wishes, that what sort of treatment patient doesn't want, what sort of place he wants to die, what medications he wants while he's dying. Okay. And okay, if there is any other you would say that, okay, if there is any other treatment, or any place you would like to, if any treatment you would like to take or you would like to refuse. Okay. And we can document that as well. And what kind of painkillers would you like to receive? Painkillers. Okay. And where would you like to, if your condition becomes worse, and we do not expect any recovery, so have, what place would you like to die at, whether it's a home or at the hospital? Okay. So where would you like to get admitted and treated in your last days? So we can put everything in writing. And then ask about funeral arrangements. That, okay, the last thing I would like to discuss with you is about that some people they make their funeral arrangements before they die or in their life. So have you ever thought about it? So patient would say, yes, doctor, I have already I've signed a bond with I have already signed a bond with funeral services. So doctor would say that, okay, that's fine. Then you can discuss, you will be discussing those with the patients end of life care, the patients who are towards the end of life. For example, patient with neutropenic sepsis, patient on chemotherapy with neutropenic sepsis, and patient with the heart failure, or if they do not want to continue any sort of treatment. So let's have a look at scenarios. Okay. Pneumonia, patient refusing treatment, end of life. Okay, this is end of life. So same approach would be applied, that FR2 in acute emergency. Patient is a 75 years old man who was admitted yesterday with infective exacerbation of COPD. He had a cabbage 15 years ago uh, after severe MI. 3 years ago, he developed heart failure for which he is taking medications. He is currently taking antibiotics through the vein. He has told one of the nurses that he doesn't want to take some of those medications. Please explore why the patient doesn't want to take medications. Discuss the consequences of not taking medication. Address any concern that patient may have. Discuss further management. Okay, so same approach would be followed here, which we have discussed shortly. Then start with the grips. Say that, okay, I understand that you have been having some concerns, and you have talked, the nurse has told me or whatever. You can say that, okay, I understand that you had some concerns, you wanted to talk about your treatment to one of the doctors. Please go on, I'm here to talk to you about it. Please tell me about your concerns. What medication I heard that you want to stop medication. What medication would you like to stop? What medication are you taking currently, and why are you taking those medications? Explore. Okay, explore about the medication, and what medication you do not want to take. And he would say that, doctor, I want to stop all my regular medications. You would ask that, okay, can you tell me the reason why you want to stop those medication? Patient would say, doctor, the medications make me drowsy. I feel tired all the time. Even if I take medication, I do not have any improvement. So you need to assess his mental capacity. Okay, so you would be saying that, okay, can we go through everything just to have a better understanding about your situation? So what is your understanding of your medical condition? Okay, how long have you been sick? Do you know why have you been given this medication? And do you understand what would happen if you stop this medication? Okay. Did anyone explain to you the consequences? Patient would say, yes, doctor, I understand. I do understand. And then promote his next best interest, and say that, okay, the main reason that you are feeling drowsy is because of the cholesterol medication you have been taking called simvastatin. That is the reason for your drowsiness. You feel tired and develop chest pain as a complication of your heart failure. So if we try and change your cholesterol medications to a different one that doesn't cause drowsiness and review some of your heart failure medications, do you wish to continue with your medications? Okay, this is the next best interest that you have discussed about the medication, cholesterol medication and heart failure medication, that if we reduce the medications or if we change the medication, if we put you on alternate medication, would you still continue to take your medications? So if you stop, you have to tell the patient that if you stop taking medications, it would worsen the chest pain. Our advice would be to continue taking this medication. All right. And he would say, no, doctor, I have already decided to stop taking all my medications. Then you would say that, I'm sorry to hear that you feel this way. How long have you been thinking about stopping this? Do you feel low? How is your mood these days? And do you have any other stress at all? Any financial issue? Any problem? Any worries, including housing? Okay. So what is the most important thing for you at the moment? And then psychosocial history, more social history, that who do you live with and who else is in the family? Have you discussed it with your family? Have you discussed with your daughter? Patient would say, yes, doctor, I haven't discussed it with her, she would stop me. And then accept their decision at the end. And then you should say that, okay, as a doctor, we cannot really force you to take this medication, we cannot force you to stay in the hospital. As long as you understand the consequences of stopping your treatment. But in order to do so, you need to sign some papers that you are stopping against medical advice, that you are stopping your medication or treatment against the medical advice. So you need to sign a document. Okay. This was the same case with that IV drug abuser who left, who wanted to leave the hospital. That if he left the hospital, so he needed to sign the documents. So This was all, and then the chapter 2 begins here. Discuss about this advanced directive, discuss about you should be able to discuss these things, that okay, let's appoint somebody as lasting power of attorney, and CPR, assisted ventilation, and about this what was that? Yes, wishes, treatment, medications, and funeral arrangements. Okay, so you need to ask about, you need to discuss all those things. The next scenario is patient refusing chemotherapy. FY2 in oncology department, patient is a 75 years old man who has been admitted with neutropenic sepsis. He was diagnosed with lung cancer 1 year ago. He's on chemotherapy. The tumor has significantly shrunk. So it means that he has responded to the treatment. He is receiving antibiotics for sepsis and responding well to this. He has told one of the nurses that he would like to talk to a doctor about his management, talk to the patient and address his concerns. We can say, in case you change your mind, please let us know. We will be happy to help. Yes, yes, Sudhan, you can definitely say that. That's a good sentence over there. In case you change your mind, you can let us know. We can help you. Yes. You're welcome. Okay, so it's a same scenario, same approach, but here what we will be doing is the patient would like to say that, doctor, I do not want to take this antibiotics you give me every time. I'm not going to take chemotherapy. Every time you give me this chemotherapy, I get sick because you develop neutropenic sepsis. It's a side effect of chemotherapy, that it weakens the immune system, it destroys the normal cells as well. So what you need to tell the patient is that, okay, you will be addressing his concern. You will tell them that, okay, every time he says that I have to come to the hospital and receive this extensive course of antibiotics, so I do not want to continue with it. And then you will tell the patient that, okay, you have to tell the patient that we have your reports say that your tumor has significantly shrunk. It means that you have responded, that your treatment is going well, which means that tumor cells or your body has shown good response to the treatment. So we would suggest you to continue your treatment. At the end, the patient might be convinced. He would say that, okay, doctor, I would like to continue, but I do not want to come to the hospital. What about antibiotics? And then you can address his concern. You can tell him that, okay, because his main concern is coming to the hospital and receiving these antibiotics every time, getting admitted in the hospital. He doesn't want to stay in the hospital and continue chemotherapy. The ultimate reason for not staying in the hospital is because he is taking he has been given IV medication after admission in the hospital. So you need to tell him, you need to give him alternate option that, okay, if you continue your chemotherapy, what we can do for you is that we can ask community nurse to visit you. Okay, they can give you this treatment at home. They can, every time after chemotherapy, we can they can continue. You get sick, so they can continue your antibiotics at home. They would visit your home and they would be giving you this treatment. So how does that sound to you? The patient might agree to you, and that he might become happy that, okay, doctor, I do not that's fine if you want me to, because you need to understand what is the main concern of the patient. It is not that, okay, doctor, he's saying that, "Oh, I do not want to take chemotherapy," and then you said, okay, if you don't want to take, okay, oh, fine, do not take it. It's your autonomy and I respect patient autonomy. No, you have to explore the concern, see if you can help, because you will be giving him options. He would say, doctor, I cannot come to the hospital for this medication. You will tell the alternate with it. Okay, doctor, all right, what we can do for you is we have other option that you can receive this treatment at home as well. He might be saying, okay, so doctor, tell me about this. You will tell that, okay, we have community nurses, they will be visiting you, or healthcare workers, they will be visiting to you to give you antibiotics at home. At the end, he might say that, okay, I'm okay to receive medication, if as long as they are going to give me medication at home, I'm okay to receive it. I have no concerns. He might agree to you. And in this case, you can discuss the chapter 2 as well, okay? Because he is well at the moment, you can discuss it with any patient refusing treatment, or any elderly, any patient with this problem, chronic, like they are terminal. So you can discuss it in all those 4-5 scenarios that, okay, have you appointed any lasting power of attorney? And because this is the time you are having sound mind. But if your condition gets worse, you may not be able to take a decision on your behalf. So there should be someone who should be taking decisions, okay, and discuss other options as well. It's okay. The patient, there's a patient with prostate cancer. This the management is same, pretty much same. Mm, pretty much same. So the next scenario is patient with prostate cancer. You are FY2 in the urology department. Patient is a 70 years old man who was admitted with urinary retention this morning. He was catheterized and he is now well. He's asking the nurses to remove the catheter. He wants to go home. He has prostate cancer. Speak to the patient, assess his mental capacity, and discuss further management. So the same approach here. The patient does not want to stay in the hospital and wants to remove the catheter. So you need to now ask the patient that, okay, what do you understand about your condition? So do you know that if we remove, what treatment are you taking? What would be the consequences if you stop? And you, okay, do you know why you are catheterized? Okay, and why are you having this catheter in place? So he would say, doctor, I was having urinary retention. I could not urinate. That's why they passed this. I have enlarged prostate, and that's the reason they passed the urine. They passed the urinary catheter. So you will tell that, okay, do you understand if we remove this catheter, what would happen? So he would say, yes, doctor, I just want to go home. And you would be telling that, okay, if you go home, I'm afraid that you might develop this urinary retention, because in a day or two, you will need hospital admission again, because you won't be able to urinate on your own. You won't be able to pass urine on your own. So we suggest that you should leave this catheter in place. We recommend that it should be in place, so that your condition might not get worse. So you can explain it, okay? And then mm, same approach you have applied. There are some concerns which I've already discussed with you, okay? Sometimes the patient is the patient with prostate cancer, and another scenario is patient with bladder cancer, okay? Let's see where it is. Where is that scenario? Yes, here it is. Patient with bladder cancer. You are about to in urology department. A 75 years old man was admitted in the morning with urinary infection. He was given IV antibiotics. Talk to the patient regarding inserting an IV cannula. Address his concern. So this is the patient. He's not letting insert cannula. He was admitted because he had UTI. After bladder cancer, he had UTI. So this patient was not letting to insert cannula. So you need to talk to the patient and discuss the importance of insertion of cannula and treatment. You need to assess. You have to follow the same approach, starting with the grapes, assessing mental capacity, exploring the concerns, why they do not want. So why they do not want to insert this cannula, and also why they want to leave the hospital. Okay, why don't they want to receive this antibiotics? And then what you need to do is the same management you will be discussing, and then you will be discussing chapter 2 after they have done. They do not agree to your proposal. Okay, so what you can do is you have to respect patient autonomy, and you need to let them go home. And after getting written documents signed by them, and then what needs to be done is you need to discuss that advanced directive, okay, or advanced care plan with them. All right. So the next is DNAR multiple sclerosis. It's the same that, okay, yeah, FY2 in GP and visiting a patient at home. Patient is an 82 years old lady who has been diagnosed with end stage multiple sclerosis. She has been informed about her disease. Consultant has seen the patient and discussed the end stage details of multiple sclerosis. The patient is fully aware of her condition. She's on palliative therapy and has a palliative nurse. Talk to the patient about end of life discussion and fill in the documents provided. Okay, this scenario you might not be getting this scenario. This is more practical scenario, because it needs the scenario is demanding you to sign to fill the documents. Okay, so it is GP, you can say GP's responsibility. to fill those documents, okay, in the presence of a solicitor. So this scenario is more or less not that important and not relevant, because you won't be asked to fill in the forms. Rather, you can be asked to talk to her. She might be, scenario might be somewhat modified, that okay, she does not want to continue her palliative therapy. So you would have to discuss it with that patient. All right. The next thing is patient refusing treatment is warfarin. And after that, we have ectopic pregnancy. Two scenarios for today, for tonight, and then we will wind up this session. We just quickly go through this. A URFI2 in acute medicine, patient is a 55 years old man. That was the previous scenarios we discussed were this end of life discussions. You had to discuss that what you say, advanced directive plan, advanced directive or advanced care plan as well. Okay, you had to discuss all the consequences. In these scenarios as well, you have to assess the mental capacity, go with the same scenario, doing with the grapes, assess mental capacity, explore their concerns, why don't they want to take the medication, okay? And then you have to address their concerns. Okay. Then okay. URFI2 in acute medicine, patient is a 55 years old man who was admitted 5 days ago with palpitations. He has been diagnosed with atrial fibrillation and placed on digoxin, Clexane, and warfarin. He is about to be discharged home today with warfarin, but he has been reluctant to take it. The nurse has advised him to take it. Patient had a stroke and myocardial infarction 2 years ago. Talk to the patient, assess the mental capacity to take warfarin, and discuss further management. Okay. So you have to go with the same approach. You will be asking the patient that, okay, what is the reason you don't want to take it? He would say that, doctor, why are you going to give me this rat poison? I don't want it. And then you will be saying that, okay, let me explain it to you, that why you have been given this medication, and why do you think it is rat poison? Why would you say that? What do you know about it? Okay. So then the patient might tell you that, okay, don't you know this is a rat poison? So you should tell that, okay, yes, you're right. Some rat poisons may have this same component, but is there any particular reason why you are reluctant? Are you afraid of anything? Then he would say that, doctor, my father had brain hemorrhage or bleeding in his brain while he was on the same medication, so he died. And then you need to use this Eve protocol over here, that I'm really sorry. I can see that you are really upset. You are really worried. I'm really sorry. I'm really sorry to hear about your father. So I understand why you are reluctant. Now it's clear to me. Okay. So I would like to ask you a few questions to know how much have you been told about your condition, and then assess mental capacity, and then check. Okay. Then fill in the gaps by promoting the next best interest. Okay. Tell him that, okay, you have got this condition, atrial fibrillation, which is irregular beating of the heart. And people with this condition have risk of developing a clot in their heart, which can go to their brain, and it can cause stroke. Okay. And warfarin is a blood thinning medication which can prevent clot formation in someone who has this kind of irregular rhythm. Okay. And warfarin, we are giving you this warfarin because warfarin can be monitored. That's why you need not to worry about it. The bleeding only happens when you have an excessive amount of warfarin in your body, but that can be monitored. Okay. So this monitoring system, tell about the monitoring system. That this monitoring system is called INR system. There's a team of people who can involve with you to help you with such with warfarin treatment. Such team involves your GP and anticoagulant clinic as well. Okay. So in worst situation, you have in the worst case scenario, if you have high amount of or high concentration of this medication in your blood, we can revert it back with the help of another medication called vitamin K. Therefore, you don't need to worry. There are many people on warfarin who are warfarin, and they are doing very well without experiencing any serious complications. Okay. We would highly advise you to continue with warfarin. And you also mentioned rat poison. Okay, so you need to tell that, okay, red poison may be made in a similar way, but it is highly concentrated form. So that it means that it is 10 to 100 times concentrated, and the medication that we are going to give you is a controlled dose. And the reason it is called rat poison is because it was once it was used to cause bleeding in the rats. That's why it is called rat poison. And if you take the right dose of the warfarin is quite safe. It shouldn't be any problem for you. Okay, and what do you think about we discussed? And then you have to tell, you have to ask the patient that, okay, uh, is there anyone who can remember? I understand that there is a scenario that the patient is having a stroke. Yes, this in this scenario it has been mentioned that the patient is having stroke. Patient is, yes, he had a stroke. So you will be telling that, I understand that you had a stroke as well. So do you remember, how well do you remember the things? So is there anyone else, have you got me, have you understood whatever we discussed so far? Okay, how well you remember the things? I understand you had a stroke, so can you tell me how well you remember the things? He would tell that, okay, uh, is there anyone who can explain the things to you? He would say that sometimes my wife explains it to me, and sometimes I write down the things. And then you can tell, okay, would it be helpful if I write it down, whatever we discussed? Would it be helpful if I write it down for you? He would say, yes, doctor, that would be great if you write it for me. Okay. Is the question how his father's concerned? Yes, Clara, you can explain it for his father's concern. You can say that, I'm really sorry. I'm not really sure about your father's condition, but it could be an unfortunate situation. And I'm not having at the moment, I do not have his notes with me. So I do not know, or I'm not really sure what exactly happened to him. But I'm sorry to hear about your father. Okay. You can simply say that, instead of going into the details, or instead of saying something you do not know. You should simply reply with it that, okay, I'm sorry, at the moment I do not have his notes, so I cannot comment on his condition, or I'm not really sure what happened to him. Okay, but I'm having your notes with me, so I can tell about your treatment. You're welcome. Okay, so the next scenario is ectopic pregnancy, the last one, last but not the least. I got this scenario in my PLAB 2 examination, and I passed it with good marks. So the thing is, when I entered the cubicle, you have to pick up the verbal and the non-verbal cues as well. There was a female sitting, and she was holding her right side, right side of her tummy with her left hand, and she was like sitting. She was uncomfortable, and she was continuously shaking and moving her head like she was in pain, and she was also uh, uneasy. She wanted to go home. She wanted to leave the hospital. She was really concerned. And the reason for her concern was that she thought that her parents would come to know that she is in the hospital. So the main reason here is that she doesn't want to remain in the hospital. Okay. So FY2 in, you are FY2 in obs and gynae. Patient is an 18 years old girl who presented with right-sided lower abdominal pain. She had a urine pregnancy test which is positive. And ultrasound scan has been requested but not yet done. The hospital protocol states that patient can't be allowed to leave hospital without an ultrasound scan. But ultrasound cannot be done until next morning. So basically, you have to convince this patient that, okay, you have to remain in the hospital unless we make sure that your condition is not a serious one. We have to rule out ectopic pregnancy because the pregnancy test is positive and she's having abdominal pain as well. And it could be appendicitis as well, but we need to rule out ectopic pregnancy. Okay, so do not jump over to the diagnosis of ectopic pregnancy straight away. So you have to, you will be going inside. Do not presume the diagnosis that, okay, it is ectopic pregnancy. Yes, definitely it is ectopic pregnancy. You do not have any other scenario like this, but do not make diagnosis beforehand, before going to the cubicle. Okay, once you enter the cubicle, pretend as you do not know anything, because if you will be thinking about if ectopic pregnancy is in your mind, then your mind will be limited, questions will be limited, you will confine in that ectopic pregnancies topic. So you need to think on broader perspectives. All right, so when you enter the room, you need to ask, okay, how can I help you? Or you can just simply say that, okay, I can see that you are a bit uncomfortable, you are holding your tummy, or I can see that what is wrong with you, could you please tell me what's happening? She would say, doctor, I have pain in my tummy, and then take a history of the pain, and then slowly and gradually go for, she will be discussing it with you, and she will, at the end you will come to know, okay, I would like to go for examination and everything. uh, you can mention that, okay, I understand that you had a pregnancy urine test as well, which shows that you are pregnant. Do not say that your urine pregnancy test is positive. No, the patient does not understand what is positive. You are the doctors, you understand what is positive mean. Okay, so you would say that, okay, you had a urine pregnancy test as well, which shows that you are pregnant, and we need to make sure that that your condition is not serious one. So for that, we need to do an ultrasound scan. For that, you have to stay in the hospital tonight, and we will be making sure everything is fine, and then we can discharge you home. She would say, no, doctor, I do not want to stay in the hospital because my parents, I haven't informed my parents, and they would come to know that I have visited the hospital. You would tell the patient that, okay, whatever we discuss will remain. We would not disclose it to your parents, and unless you ask us to inform your parents. Okay, we won't discuss anything with your parents. Whatever you discuss with us will be between us and the medical team. Okay. It is basically, you need to negotiate. You have to take history, greet, take medication history, medicine history, menstrual history, sexual history, go for differential diagnosis like appendicitis, acute appendicitis, pelvic inflammatory disease, gastroenteritis, UTI as well. Okay, and then go for all that PMA, Holy Family, Desatoli, the history, and then social history. You need to ask about the relationship. It's very important. When you will be asking sexual history, ask about the relationship history as well. Okay, and then you have to explain the diagnosis that, from what I gather, after listening to you, having listened to you, and combining the examination finding, I would like to examine her, and when you will discussing the diagnosis, okay, combining it with examination findings, it seems that you might be having a condition called ectopic pregnancy, which is pregnancy outside the womb. So we need to perform an ultrasound scan, but due to some reasons, uh, uh, ultrasound scan cannot be done until the next morning. Okay, so your condition needs monitoring. That's why we advise you to get admitted and remain in the hospital until we make sure that you don't have this condition. We are suspecting this at the moment. Okay, you might be having this condition, means that we are suspecting. It is not that your condition is ectopic pregnancy, that you are having this ectopic pregnancy. No, we are suspecting, or you might have this condition. Okay, and would that be okay for you to remain in the hospital? She would say, no, doctor. Explore any concerns. She would say, doctor, my parents would come to know. Then you have to tell the doc, okay, don't worry. We are not going to inform your parents unless you ask us to do so. Okay. And then, uh, mm, then you tell the patient that if we let you go home, you might bleed a lot, and there might be bleeding. She would say, doctor, I would come back if I have bleeding. Then you have to tell that, let me tell you that this is not an ordinary bleeding. The bleeding would be more severe and dangerous bleeding, and it would be occurring inside your tummy, and you might not know, you might not be aware of it, and you might not get a chance to reach to the hospital. So that's why we need you to monitor, we need you to get admitted, so that we can continuously monitor your condition. Okay. So we suggest not to put your life in danger. So we highly advise you to stay in the hospital. And the patient would say that, okay, doctor, if you say so, so I will remain in the hospital. You have to convince her. She would understand. Okay, she would understand whenever, and tell her that, okay, whenever you're comfortable to talk to your parents, we can be there, or I can be there. and we can discuss it with your parents as well, and I hope that they might understand, because they are your parents and they were of your age once. Okay, so that's all for today. Any questions so far? You're free to ask any questions.